Good evening. We'll talk today about complications of chronic venous insufficiency. As we have mentioned, varicose veins are dilated, tortuous, elongated superficial veins. And to understand what we will ask the patient about and what are the possible complications, we have to understand the pathology and physiology of the veins first. This is the normal vein. The normal vein is not dilated or elongated or short or tortuous, and the blood is flowing inside it in laminar flow. And as we have mentioned, there are mechanisms that will ensure the blood will flow from distal to proximal, and the valves will stop the blood to flow from proximal to distal. While when the patient gets varicose vein, these valves are destroyed, so the blood is flowing in both directions. So the first thing, the patient might have symptoms because of congestion of the blood in the veins. Usually the patient would have pain in the form of heaviness or aching pain, especially when he stands for a while. But what are the complications that might happen for these patients? The problem with this patient that they have high venous pressure, because the blood will be congested here because of the valves which are incompetent. With venous hypertension or high venous pressure, if this vein get injured, it will bleed a lot. So some patients will get their first presentation is bleeding from their varicose vein. And this is one of the indications to do intervention for varicose vein as soon as possible if the patient is getting bleeding from his varicose vein. So this is the first complication that might happen. The second thing, according to Virchow triad, the velocity of the blood is very important to keep the blood flowing without thrombosis. And we know that the blood flow in a way that is called laminar flow. When actually the vein gets dilated and congested, this laminar flow will change into a turbulent flow. And this turbulence in the blood flow might induce thrombosis. So these patients might be presented with superficial vein thrombosis, which was called in the past as superficial thrombophlebitis. And we have to be very clear, if the patient got varicose veins in the past, and this was complicated by thrombophlebitis without any injury of the skin, this means that this patient need non-steroidal anti-inflammatory, rest, some anti-edematous measures, and sometimes we have to give anticoagulation, but there is no role for antibiotics because this is aseptic inflammation. So thrombosis is the second complication of varicose vein. Varicose vein actually can cause thrombosis as well in the deep vein, which is not very common, but if the valve which is incompetent is close to the deep system and the clot was formed close to the deep system, this might extend into the deep system and cause DVT, like if the patient has any incompetent perforator and there is a thrombosis on top or a thrombosis close to the saphenofemoral or saphenopopliteal junction. The other complications, we can understand them from the same diagram when we have explained the edema. One of the complications of varicose vein is edema. And because this vein gets congested with blood and there is venous hypertension, so this pressure will be reflected on this venous pressure. So the pressure in the venous end of the capillary will start to rise, especially in cases with secondary varicose vein following DVT. And if this pressure is getting higher and higher, then the fluid which was filtered on the arterial side, most of it will not come back on the venous side, and the patient will have edema because of accumulation of the fluid in the interstitial fluid compartment. After the edema occurs, which is C3 in SEEP classification, the patient might proceed to C4. As we have mentioned in the SEEP classification, the C4 is lipodermatosclerosis. And what happens actually, because of the edema and the high pressure in the venous end, the pores in the capillary start to get bigger. And when these pores start to get bigger, actually some red blood cells will start to come out of the circulation. And the presence of the RBCs outside the circulation will cause hemolysis. And then the hemoglobin will be divided into heme and globin. The globin is protein, so there is no harm from having it in the interstitial fluid. But the heme contains iron, and the iron is a foreign body, it is irritant. And remember, this is a disease of superficial veins, so these veins actually between the skin and the deep fascia. Accumulation of the iron below the skin, the first thing the patient will feel is itching. The patient will have itchy sensation, and usually this will occur in the area with highest venous pressure, which is the gaiter area around the ankle. Then following that, the patient will start to have hyperpigmentation because of the iron accumulation below the skin. And because iron is irritant and it's not normally present in the subcutaneous tissue, the presence of the iron on the long term will cause chronic irritation. And as we know, chronic irritation will cause chronic inflammation, and the end result of chronic inflammation will be fibrosis. And again, we would remember that this is actually a process occurring between the skin and deep fascia. So when fibrosis would occur there, it will be called lipodermatosclerosis. That actually this is a sclerosis or fibrosis between the skin and subcutaneous tissue where the venous pressure is very high. Following lipodermatosclerosis, the patient might get into C6 in SEEP classification, which actually, because of the fibrous tissue in this area, the skin will not be normal, the hair will be lost, and the arterial blood supply locally in this area will be impaired. Then the patient might get a spontaneous, or following a trauma, a venous ulcer. And this venous ulcer will have a very high venous pressure, and this is why it will be difficult to heal. And it will occur as well in the area with the highest venous pressure, which is the gaiter area just above the medial malleolus. It might be very big and circumferential around the ankle, but it would never start as an ulcer in the foot like the ischemic and neuropathic ulcers. The patient who would have ulcer, a venous ulcer, it's a broken skin, and it will be a chronic ulcer. It won't heal within 4 weeks. As long as this ulcer is open, especially if the immunity of the patient is low, it will be always prone for infection. And this is one of the complications. Usually the venous ulcer is painless, but if it got infected, then it might be painful. This is a chronic ulcer. The presence of chronic irritation in this ulcer might transform it from being a venous ulcer into a malignant transformation, which we call it margarine ulcer, which is a squamous cell carcinoma. And usually we would suspect that if the edges of the ulcer start to get elevated, or the ulcer is not responding to the pressure compression stocking and compression dressings, then we will take a biopsy from the ulcer in the form of 4 quadrants or 8 quadrants biopsies. And if it comes back with a squamous cell carcinoma, the management will be totally different. If the ulcer starts to be deep, it might reach the periosteum of the bone, especially that the gaiter area is very close to the shin of the tibia. So if it reaches the bone, it might cause periostitis. Usually it will not proceed to osteomyelitis, but usually it will cause local infection in the periosteum, which is periostitis. So these are the main complications of chronic venous insufficiency. And to understand the pathology, this will help you to know how to ask the patient questions in the history taking and how to manage them in the future. Thank you very much. I'm hoping that you got useful information, and you will leave your comments and questions below the video, and I will answer them as soon as I can. Thank you.